Welcome to the latest installment of the AST Journal Club series. Today's Journal Club features the AJT article, awarding additional MELD points to the shortest waitlist candidates improves sex disparity in access to liver transplant in the United States. This session is hosted jointly by AST's Liver and Intestinal Community of Practice and AST's Women's Health Community of Practice. Our moderators for today's session are Dr. Alexandra Shingina from Vanderbilt University Medical Center and Dr. Helen from University of Southern California Keck School of Medicine. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's webinar. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This Journal Club is being recorded and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note that your lines have all been muted so that only the presenters can be heard clearly for the archive recording. If you do have a question for our panelists during the Journal Club, we encourage you to participate using the Q&A button in your Zoom webinar panel. Questions submitted via the chat window may be missed by our moderators. If there are any questions that we do not have time for, we will either answer them individually offline, or we will post the full question with the answer to the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Shingina and Han, to begin our presentation.
Thank you so much, Brian, for that introduction. So we would like to welcome and thank everyone for joining this AJT AST Journal Club. Dr. Helen Han, who's my co-moderator from USC, and myself will be moderating this session. Dr. Han is an assistant professor of clinical medicine at USC. Her areas of interest are living donor liver transplant and alcohol-associated liver disease. She currently serves as a medical director of the Living Donor Transplant Program. She's also the program director of the Transplant Hepatology Fellowship. I'm currently the assistant professor of medicine at Vanderbilt University. I also serve as a medical director of the Living Donor Liver Transplant Program here, as well as hepatology director of Combined Heart Liver Transplant. And we are both very excited to be a part of this journal club that highlights the medical community efforts at addressing disparity in patients with liver disease, and specifically those undergoing transplantation. As many of you are aware, this has been an active field with several modifications to current allocation systems that have been proposed to try to minimize the sex disparity that results in lower transplant rates and higher waitlist dropout for women listed for liver transplant, including the current study that we will be discussing that came out of UCSF by Dr. Mehta and colleagues. And it is my pleasure to introduce Dr. Neil Mehta, who is a transplant hepatologist and associate clinical professor at UCSF. He is the director of both liver cancer multidisciplinary program, as well as the medical director of the Living Donor Program. His research focus is primarily on selection criteria and liver transplant outcomes, both for patients with and without HCC, including improving transplant access and minimizing waitlist disparities. And I will turn it over to Dr. Mehta now.
Thank you so much for that kind of introduction. It's really great to be here. I'm also joined by Dr. Bernard, who was the first author on this publication, and excited to have a discussion after we talk about the article. But thanks again. And here are I don't have any relevant disclosures for this webinar. And I wanted to provide some background, mostly because of what Dr. Shingina was saying, is that there's been a lot of publications coming out recently on this topic, and it's, so I just wanted to make sure we're all on the same kind of plane before we discuss our data. And so I think probably most of the people in this webinar know that, MELD sodium for the most part has been, good and has advanced our field tremendously. It appears to be an objective measure of disease severity. It has led to reduced overall waitlist mortality and has also improved racial ethnic disparities. So obviously, mostly good things. But MELD sodium could be better, and especially for certain populations. And so what does MELD not accurately capture? Well, we're not going to discuss a lot of the things that MELD is kind of limited in terms of renal function, indications of disease etiology, such as HCC, over prioritization, mostly for men over the years, as well as some of the subjective nature of liver transplant allocation and sex disparities. So, but what we are going to focus on is body size, specifically options, including height or body surface area, in the sense that if two recipients have the same MELD, the shorter ones or smaller ones will typically have a much more difficult time finding a liver. And so that decreased access to donors for smaller or shorter patients lead to significant disparities that Dr. Shingina was describing at the top of the hour. So in general, two patients with the same urgency or kind of need for transplant should have an equal chance of liver transplantation. That's kind of basis of the final rule. And that should be regardless of any other factors such as sex, race, social determinants of health, SAS status, height, etc. So why does MELD need improvements? We know that women and shorter patients remain disadvantaged. They're more likely to be delisted as too sick for transplant. They're more likely to die on the wait list, and they're less likely to undergo transplant. There's been several studies on this topic. I'll highlight a few here. And so this is a study from now almost 15 years ago by Moylan and colleagues in JAMA that showed that when you compare women to men, the adjusted odds ratio in the post-MELD cohort of patients without HCC had the 1.3 times higher odds of death or becoming too sick, as well as, for liver transplantation, we saw very similar numbers here. And so this is kind of a problem that's held true both pre and post MELD, that women have had higher rates of death or becoming too sick for transplant, as well as lower rates of liver transplantation. And more recent data from Lauren Nephew and other colleagues and other authors have looked specifically at kind of size and donor recipient size mismatch. So deceased donors are more often men, and men are often bigger. And so body surface area, BSA, has been associated with rank position and organ decline. So this is data from CGH from Lauren Nephew using UNOS match run data from 2007 to 2013. Showing that men are more likely to ever be ranked first on the match run. Women are more likely to have an organ offer declined while ranked first, as well. And this is most important, is that the decline while first is often related to donor recipient size mismatch. And kind of similarly from the same article, that you can look at just how many organ declines related to sex. And you can see here that if men with one organ decline as the reference, you can see that women with one organ decline, 2 to 4 organ declines, and 5 or more organ declines have much higher odds of becoming too sick for liver transplant or dying. So this is a common problem that we think is related to donor recipient size mismatch. Basically, the common refrain here is that it's much easier to put a small liver into a big person than a big liver into a small person. So, one of the breakthroughs last year in this field was MELD 3.0, which was a multi-center kind of effort of authors looking at kind of a national data to try to refine MELD sodium. And so if MELD is MELD 1.0 and MELD sodium is 2.0, this was MELD 3.0, looking at multivariable smoothing splines that included not just bilirubin, INR, creatinine, and sodium, but also included albumin here. And you can see the influence of these 5 variables on death within 90 days. And so MELD 3.0 was basically proposed to add albumin as well as to add sex. And so in this kind of MELD 3.0, females would get the categorization was 1.33 as a coefficient. And you could see how, and so that would be kind of moved into the calculator along with those 5 other variables to kind of reprioritize patients on a single waiting list. The authors found good C statistics and basically estimated that the new score would reclassify approximately 9% of patients who died while waiting and reduce approximately 20 waiting list deaths per year. So, certainly MELD 3.0 is an advance, but it doesn't have the focus on height that probably the field still needs. So not surprisingly, donor and candidate height distribution is exactly the same. That's, we would expect that. So on average, our median height for donors and candidates are 172 centimeters. And you can see that whether you use various different height kind of thresholds, you can see donors and candidates tend to have the same thresholds. And women end up being about 40% of donors and about 36% of candidates. But when you break up, not surprisingly, height or body surface area by sex, you can see here that the average female is 15 centimeters shorter or 6 inches shorter than the median for males. And similar, you can see that body surface area is as much smaller for female candidates than male candidates. This is a publication from some of our UCSF partners a couple of years ago in AJT that show that height explains a substantial proportion of gender-based disparities in waitlist mortality among waitlist candidates. And they found in this study that basically a height cutoff of 166 centimeters was a good place to start, and shorter patients than that would have increasing risk of waitlist mortality compared to taller patients. And so that was kind of the background for this current study. But I did want to point out kind of an analysis from the MELD 3.0 analysis that Allison Kwong and colleagues were graciously shared for this presentation. Basically, that when you look at kind of different categories, specifically, what if you compared short women to tall men? Not surprisingly, short women would have lower rates of transplant and higher rates of death. But importantly, when you look at short women versus tall women, short women have lower rates of transplant and higher rates of death, suggesting it's not just a all sex, it's a short or a shorter, smaller stature issue, such that if you compared short men to tall men, shorter men have lower rates of transplant. And importantly, when you compare short men to tall women, shorter men have lower rates of transplant. So just to kind of summarize the background, accounting for height or size, there's a tendency to use smaller donors for larger candidates, making smaller donors less accessible for small candidates. This issue disproportionately affects not just females, but also Hispanics and Asian candidates. And female sex associated with higher risk of waitlist mortality has been shown over and over again. In part, that's going to be addressed by MELD 3.0, but short stature appears to be associated with lower probability of transplant and likely needs a different or additional policy solution. And so this brings us to our article. So this is awarding additional MELD points to the shortest waitlist candidates to improve sex disparities and access to liver transplant in the United States. So our population was SRTR patients who were waitlisted from 2014 to 2019. We then used LSAM, liver simulation modeling, to model waitlist outcomes in several versions of awarding. So we basically wanted to award additional MELD points based on height categories and compared to that to the original or current policy. And that's one of the nice things that LSAM allows you to do. In terms of height categories, we basically initially started by roughly dividing the population into thirds by height, rounded to the nearest centimeter. The tallest third was the greater than or equal to 176 centimeter group. And then we chose the range for the next third to kind of correspond with the findings from G et al. That 166 centimeters appears to be the threshold by which we start to see worsening outcomes. And then to better study the disadvantaged shortest third, we then subdivided those into three groups: less than 150, less than or equal to 150, 151 to 156, and then 157 to 165. So we did 10 LSAM runs that were performed, each including current policy and the various proposed policy changes. Our primary outcome was waitlist outcomes, specifically either dropout from the waitlist or transplant. In the SRTR modeling, dropout can be due to either death or becoming too sick for transplant. LSAM unfortunately doesn't account for dropout and just counts death while on the waitlist or within 90 days after waitlist removal. And so here's the SRTR data. This is not new, relatively speaking. This is similar to what Genji had found earlier, that if you look at either percent undergoing transplant, percent dropping out, or percent dying, these are highly correlated with height. And these kind of the size of the circles correspond to the normal number of candidates at each of these different height markings. For example, when you look at transplant proportion, you can see this is under 42% for the shortest patients, all the way to greater than 50% for the tallest patients. Similarly, dropout proportions around 24%, or a quarter of patients of the shortest group, all the way down to only about 16% of the tallest group. This is our kind of table one from the SRTR range. And you can see here that we've grouped our patients into the 5 height ranges. Most important here is to first show you that, obviously not surprising, that males make up the overwhelming proportion of the highest category, whereas in the shortest categories, these are almost all women. And then also, when we look at our height categories, only 2% of patients are in the shortest of 150 centimeters or less, and then an additional 6% are in the next category, 151 to 156. We also mentioned earlier that there's significant race ethnicity relationship here, such that about almost half of the patients under 150 centimeters were Hispanics, and with a sizable component of Asians as well. On the other hand, and the tallest group who has done quite well in the past, these are almost all Caucasians. So here's, again, SRTR data summarizing kind of what I've already shown you in terms of transplant and dropout rates, as well as dropout due to being too sick or dropout due to death. And I don't need to kind of rehash what I've already kind of mentioned, but this is just showing the numbers rather than the plots. So this is our LSAM results. We basically said, okay, let's make up kind of 6 different allocation kind of policies by giving differential points to these categories, just to kind of show you what these numbers mean. When we say 100 or 110 or 111, we're basically referring to these height categories. So 150, 151 to 156, 157 to 165. So these are the shortest 3 groups. So 100 means giving 1 extra MELD point at all times to this group, and giving 0 to everyone else. 111 would mean giving 1 point to each of these 3 groups and 0 to everyone else. Okay, so that's what this refers to compared to the original policy. One thing to point out is that the transplant percentage differences amongst categories in LSAM is not as different as it was for SRTR. And same thing with the death percentages. So SRTR kind of real world data is showing a bit of a bigger problem than what LSAM is simulating. So if we did our first scenario, 100, meaning giving 1 additional MELD point to the shortest 2% of patients at all times, that would improve their rates of transplant. Would not necessarily improve the second shortest group at all, not surprising. And you don't see really huge differences in the outcomes for the other 3 groups, and that's mostly because this is only 2% of the population. So this probably is not enough. On the other hand, what about 3-2-1? What if you give 3 points to the shortest 2%, 2 points to the shortest 6%, and then 1 point to the next 25%? This appears to be too much. We're probably over prioritizing transplant for that group. And so we thought maybe a couple others might be just right. So what about 210, giving 2 extra points to the shortest 2% and 1 point to the next 6%? You can see here that we are increasing transplant rates in LSAM, actually such that the shortest 2% would do the best in terms of transplant percentage, but still would have the highest death percentage. So that's something important to note. And we actually plotted this graphically, and these are figures that are also in the manuscript. And this is just a nice way to show black lines being the original policy for percentage of transplants, and then what would happen with this new policy. You can see, and this is graphed, so you can see the percentage of candidates. And so that's why we like this kind of way to show it, that this 2% would do much better, this 6% would do better, and then there'd be relatively minor drop off in the other 92% of people, knowing that liver transplantation is a zero-sum game. Another policy that we liked a lot was 110. Oops, I highlighted the wrong bar. I apologize for that. We're focused here on 110, where you again see improved outcomes in the shortest 8% of patients. But again, in this one, you still do have a relatively high death percentage here for the shortest 2%. But again, we can see this graphically kind of similarly. We're trying to get a relative equalization of percentage of transplants across this rate, not just percentage of transplants, but also percentage of death while awaiting transplant. So we thought the strengths of these findings are the data is based on a well-characterized SRTR data set. We thought that this proposal would give additional MELD points to a relatively small subset of waitlist candidates, specifically the shortest 8%, whether you would do a 210 or a 110. And these are the ones who appear to have the worst waitlist outcomes. Importantly, we think that short men would benefit from this policy. There's not a ton of short men in these categories, but there are some. And that's something that MELD 3.0 wouldn't account for, as well as MELD 3.0 would give tall women additional priority, whereas short and tall women wouldn't really get differential priority versus in this policy proposal they would. And also our strength is that LSAM is a well-established tool for modeling proposed changes. LSAM is how we decided on a 6-month wait for HCC. It's MELD 3.0 used LSAM as well. And it's been used for previous changes to allocation. And so we thought that was important to do here. In terms of limitations, probably one of the most important limitation is that for a lot of these different policies, including MELD 3.0, sex and height are collinear. And so it's really difficult to assess the effects of the two variables separately and reliably. LSAM also, unfortunately, isn't able to identify dropout events like SRTR or UNOS star file can, specifically removed from the waitlist for being too sick. And so that's a problem, and by which LSAM we really had to focus on transplant percentage and death percentage. Also, I mentioned this earlier, but both SRTR and LSAM data show increased risk of death and decreased risk of transplant for shorter patients, or I should say decreased likelihood of transplant for shorter patients. But the absolute values were more varied in SRTR than LSAM. For example, we saw those from the shortest group to the tallest group. There's a difference about 12% for transplant percentage for SRTR, but it was only about 6% for LSAM. And then finally, LSAM cannot consider the availability of small organs for transplant because it currently doesn't model donor-recipient size matching, though that is something that us and a lot of other groups have really strongly encouraged LSAM to take into account in future iterations. And so to summarize or to conclude, we believe that awarding an additional 1 to 2 MELD points to the shortest 8% of liver transplant candidates, either with a 110 policy or a 210 policy, would improve existing disparities in access to transplant for this group, which is largely comprised of women. We also don't want to take away anything from MELD 3.0 or other policies that can consider allocating small based on body surface area donors for small recipients, among other policy changes. So for example, prioritizing pediatric livers to women and offering women-sized reduced or split livers. Based on, there's been a lot of data in this field. Women who receive pediatric donor first offers had lower waitlist mortality than women who received adult donor offers first, for example. And so I think there's a lot of work that's yet to be done in this field related to size matching, split livers, organ offer in general. But for the purposes of our work, we do think that awarding additional MELD points to the shortest candidates would improve existing disparities. I think that's my last slide. I think I'm at my 25-minute mark. And so I thank you for listening to this presentation, and happy with my panelists and moderators to kind of open it up to discussions and questions. Thank you very much.
Thank you so much, Neil. That was a beautiful presentation. I just want to remind our audience to put in any pressing questions they have for Dr. Mehta and Dr. Bernards into the Q&A so that we can free up the chat. But just to kick off the Q&A, I would like to ask Neil, because we are living donor folks. I mean, why not just living donor liver transplant? And you know, and I'll have you answer that for us, right?
Sure.
Because
yeah. No, I think it's a great point. I mean, we talk about splits, right? And what kind of better split than a live donor transplant? You know, I think it makes a lot of sense. I think when you're thinking about a shorter patient, you know, they might not even need the right lobe of a donor. They may even be able to get away with a left lobe for centers that do left lobe live donor liver transplantation. I know not all centers do, but certainly some do. So that would be one advantage. I think it's great. I think we'd certainly offer that anytime we have patients come in at UCSF who are blood type O or don't have an obvious pathway to transplant and they're shorter. We definitely, you know, are trying to really push live donor transplant. Unfortunately, live donor transplants only make up 4 to 5% of all transplants in the country. It's despite everyone's best efforts, the numbers of live donor transplants has gone up like basically 0 in the last 15 years. And so I think it makes a lot of sense, but for whatever reason, the community hasn't really got behind it. And by community, I mean, not just kind of pushing efforts on the transplant center end, but also on the community end from recipients, donors, et cetera. And so I know there's been great efforts, but it just hasn't really, you know, pushed the envelope very far. Certainly there are some centers, you know, we'll single out Pittsburgh, for example, who've done, you know, great in terms of increasing their numbers. And I'd love it if other centers could increase that similarly if possible.
yeah, absolutely. That was just our pitch for living donor liver transplant.
Always.
And so while we wait for some other questions, I do have a question for Sarah. So how did you guys account, or how do we account with this new model and this new proposal, you know, for height changes over time? You know, because, you know, I would think that once you get to a certain age, sure, you don't have much change in height, but you're dealing with anyone over the age of 18. So, you know, was that something you guys considered or had a discussion about?
I think in the adult population, until you get to be an older adult, it's a relatively fixed, height is a relatively fixed variable. So I think we found that that was sort of an advantage of our proposal, since gender is potentially more fluid across the adult population. So I don't know if it's been studied across the waitlist transplant population, if there's any height reduction over time, but I think it's actually sort of a strength of the model.
Yeah.
Yeah, that was my sense as well. I think in general, waitlist outcomes happen relatively quickly. Certainly there are patients who are listed for many years, and maybe, you know, in that setting or like in the HCC setting, like maybe height could change slightly, but in that kind of the decompensated cirrhosis setting, of which most patients fall into, usually waitlist outcomes happen within a year. And in that case, I would expect height to be relatively similar, but we didn't look at kind of height changes. I don't think height is inputted multiple times into the UNOS database or SRTR. I think it's just kind of the one-time point.
Yeah. And I think that you mentioned at some point, you know, there's always a concern for gaming, right? But I guess that's always out there. I do have a couple questions in the Q&A box here. We have Philip Zhang, who's asking, sometimes MELD is used to reflect mortality and can influence certain clinical decisions. For example, you know, an arbitrary MELD cutoff for tips, et cetera. Do you anticipate introducing new variables into this new MELD model or policy model to influence the use of MELD in such other clinical settings?
You know, I think it's a good question. I think one of the things we've seen with MELD sodium is that we had all this data about MELD and tips, and then now you introduce MELD sodium and people are like, wait, I thought we were, what do I do with MELD sodium and tips? And so studies came out, but you know, the thing about MELD sodium is that people's MELD can change by 10 to 12 points with MELD sodium. And so that can be quite large, and it's important to study in that setting. For what we're proposing, we're only proposing it for 8% of people, and the MELD change would be max 1 to 2 points. And so I don't think, and what we're proposing isn't really someone got sicker, it's they need more access to transplant. And so at least for what we are proposing, Sarah and I are proposing, we would not, expect any other, this wouldn't really have any clinical bearing except to try to increase access to transplant for this shortest group of patients.
Mm-hmm. Another question that I would have is, I think MELD 3.0 has, recently received some approval by the board of directors of OPTN, and they incorporate an albumin aside from, the sex. And I think what your study has tried to address is that, sex can certainly be, or gender can be sort of fluid. And so you're trying to incorporate the height. How does this model compare to the 3.0? If you can comment on that at all, and maybe we'll start with Sarah.
Yeah, we addressed this some in the manuscript, and I think we have a similar C statistic, which is always reassuring. And MELD 3.0 also gives a point to all women. So that would be about 40% of the population versus we're addressing only 8% of the population getting additional points. And we don't include albumin, which is something I'll let Neil comment about.
Yeah, I mean, I think Allison's here and would love her to kind of weigh in if she's interested in weighing in. But I totally agree with what Sarah said, is that we're really not focused on all 40% of women. We wouldn't expect our C statistics to change all that much because we're really focused on a very small subset. It is a pretty similar C statistic to MELD sodium or to MELD 3.0. I think MELD 3.0 had a slightly higher numerical, but now we're in the third digit. And then I do worry a bit about albumin, but not any more than that's already been kind of thrown around in the community and discussions and what the Allison and Ray described in their manuscript and provided a model that did not include albumin. So I think it's easy to be subject to gaming. I would definitely I'm not sure why any of us would give albumin to someone anymore if we're trying to get a patient a transplant, which would be disappointing. But it feels a little different than the gaming that can happen with diuretics and creatinine. It's when you have a direct, oh, your albumin's low, give more. Oh wait, don't do that anymore. So I get a little bit worried about albumin. But I think in terms of C statistics, they're relatively similar, and without even doing extra points for more than 8% of people.
Mm-hmm. There's another question here by Emily Haas-Ryan. Is it possible for OPOs and transplant surgeons to make some of these decisions more independently? And if so, in what circumstances, or does the waitlist allocation policy determine everything? Yeah, is that something you can answer, Neil?
Yeah, I mean, not being part of an OPO or transplant surgeon, it's a little harder. So I'm happy to hear from any of our surgeons who are on the call if they want to weigh in. But I think that's always going to be tricky to make. I think obviously sometimes we'll have these freebies or these livers that just kind of are no one else wants, and so they'll just come over and they'll be like, okay, you can put this in anyone, but that's so rare. Mm-hmm. And so in general, I think independent decision making is going to be very challenging to implement. And so it seems like I don't know the exact proportion, but it seems like the vast majority of livers are offered through the standard match run policy, and so I think something like that would be very hard to implement. But certainly if there is one of those kind of freebie type livers, if it could fit into a smaller person, that would be the ideal because those patients are disadvantaged currently. Happy to hear from any surgeons on the attending here who have a better answer than mine.
I don't have any other questions in our Q&A, so I encourage the audience to keep them coming. I do want to ask you what your thoughts are with the association of stature with frailty and sarcopenia, because when it's sometimes hard to sort of piece out sometimes, those who are advanced age, they tend to be more frail, sarcopenic. Women tend to have less muscular mass they probably, they're in that catabolic state. They may end up getting more frail. So how did you kind of wrap your head around that in looking at this modeling?
Yeah, it's a great point. I'm very obviously pleased that there's so much work on frailty that's happening throughout the country, in part led by, Jennifer Lai, who has been, really pushed this field forward along with other colleagues as well. And but the point that I always think about is how the subjective nature of the delisting and the listing of patients. And it's been shown in a few different studies that women are more likely to be subjectively harmed by subjective assessments of frailty, kind of the old eyeball test, and that women are thought to be more frail than they actually are compared to men. And so whether that is directly in part related to their worse waitlist outcomes, I think is somewhat hard to say, but, certainly in clinical practice, we've seen it, and that if you think a patient's more frail than they actually are, you may be less likely to accept an offer for them. And then they may be more likely to be delisted. And obviously then their waitlist outcomes are going to be worse. So I definitely think this is part of it. But there is a very subjective nature of it, and which is why I think Jen Lai and others are really trying to get to objective markers of frailty rather than relying on the subjective eyeball test, because that's very prone to bias and is disproportionately harming women. And so I would encourage all centers to really try to incorporate objective markers of frailty into their assessments, whether it's inpatient or outpatient, rather than relying on methods that may be fallible.
Yeah.
I have a question.
Oh yeah, go ahead, Sasha.
So I was wondering if, if there was any consideration into height variation geographically among the United States. I would imagine that there are certain regions who are very heavy in, say, Caucasian population, in which case the average height would be high, versus other regions who have other populations bringing the average height down, and how this introduction of this height variable may influence the acuity circle allocation program right now.
That's great. Sarah, can you remind me, did we look at, I don't remember if we looked at any kind of geographic based height comparisons, did we?
No, we didn't, but that's very interesting, since we know there's other regional disparities.
Yeah, I agree. It is really interesting. I mean, we showed this data earlier that certainly height is very related to race, ethnicity, and certainly that's related to geography. And so you might imagine that in California, for example, when we have more Hispanics and Asians, we might have a shorter population. I agree. I think it'd be great to look into, but again, I think if we're talking about a relatively small subset of patients and a relatively, hopefully, we aren't causing effects that we don't know about. But yeah, no, I think this makes sense to look into.
The other question that I had, it was very interesting that when you divided the primary disease etiology by the height, you could see a definitive, variation of height in NAFLD and autoimmune, when it was mostly predominant in patients with lower height, and then alcohol that was higher in, do you think it's just a representation of the gender? Was it just a higher female population within NAFLD and autoimmune cohorts?
Yeah, that was, I'm happy to share that screen if that's helpful for the group. I'm just pulling it up again here. Let's see. So this is kind of what you're describing.
Yeah.
Absolutely is that alcohol tends to be more common in the tallest patients, whereas autoimmune, the other category, tends to be much more, and NAFLD tends to be more common in the shortest group. And yeah, I definitely agree that's likely driven by sex differences.
Neil and Sarah, I do want to ask you, I mean, is there a role to add height as another variable to the 3.0? Because I do think there is a role for looking at serum albumin, just like we do with child class, just like sodium really, was added to the MELD and really did address some of those patients who had significant portal hypertension and ascites. Do you think that's a model we can utilize in the future? Just adding the height as another variable to something like a 3.0 and not doing something, a separate policy.
Yeah, I mean, I think the tricky part, as we kind of touched on, and Allison and Ray's paper touched on, is that so they looked at height as well, and height was, if you want to use the word independent, but it was important. But I think they chose sex because sex appeared to be more important than height. And so the problem is that they're collinear, and so you can't. It's really hard to do a multivariable model that includes both of them, because it really, statistically speaking, just messes everything up. And so you can look at them as in a univariate analysis, and show that they're both important, but then trying to put them on the same list. It's often like trying to put MELD and Child-Pugh kind of on a similar, look at them at the same time. Sometimes you run into problems with that. And so I think you could account for sex and for height separately, but you'd be making up a little bit in terms of how much priority to give the two. Maybe fancy statisticians could figure it out, but it'd be a little tricky. But I do think that if you just account for sex, you're missing these important height differences that where short men won't be helped and tall women will be helped, when maybe that's not how it should be done. So that's kind of my long way to answer to say I'd love it if they could be on the same, if they both could be added, but I'm not sure how possible it is. But speaking of this topic, and Allison just kind of posed the question, and it's a good kind of, it ties in nicely, but it'd be great if, when we're thinking about continuous distribution, to fold in height, just like Helen's talking about, is, you might put in albumin and sex and height and put it all into continuous distribution. And there, OPUM is currently has 26 variables that they're planning on including. Unfortunately, height isn't one of them, but I've asked Dr. Hyosun and others to consider making it one of them that they can add, because it would be sad if it wasn't included in a continuous distribution policy.
Mm-hmm. So Neil and Sarah, what's the next step?
Yeah, Sarah, I don't know if you want to kind of quickly chat on what we're thinking about doing with the some of our co-authors have very fancy statistical background, and so they were trying to help us sort out who this might be most appropriate for. Right? Do you really need to be giving 2 extra MELD points for someone with a MELD of 12 to begin with? Mm-hmm. So Sarah can certainly weigh in as well, but I think trying to figure out the optimal timing and group that could benefit from this allocation. But I don't know, Sarah, if you have more to say about that.
Yeah, I think trying to identify who is most at risk for waitlist mortality, waitlist dropout, and trying to intervene in that space where they're still transplantable, but not drawing offers yet. And how can we optimize that group?
Great. Well, Sasha, do you have any pressing questions to end with?
No, but I look forward to that analysis.
Yeah.
Yeah, I mean, they sent it to us, and I didn't understand almost a single word of it. But
these are your colleagues in Hong Kong and at Carnegie Mellon.
That's right. Yeah. That's right. Yeah, and they are math backgrounds, and so everything they send along has like sigmas and deltas and hypotenuses, so it's. But yes, that is hopefully the next plan, is maybe to kind of put a brief report together of how to best, or who best and how to best, if we were going to implement this, how to do it so that we, again, as Sarah was saying, optimize outcomes and giving points where points will matter.
Absolutely. Well, we're looking forward to it. And if I don't think we have any further questions in our Q&A, but I'd like to thank Neil Mehta and Sarah Bernards for being our presenter and our discussant, to Sasha for being my co-moderator. And I'd like to turn it over to Brian Valeria, who has several announcements to make before we end our journal club for today.
Thank you so much. AST would like to thank Drs. Mehta, Bernards, Shingina, and Han, and all of our attendees for today's session. Please remember to complete the evaluation survey and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's LICOP and WHCOP, please visit myast.org/COPS or connect directly to the individual COP hubs. Thank you all again for today's great session.